A little bit about challenge we had with villages and the villages health. For those of you who aren't familiar with the villages, it's the nation's largest 55 and older active living community built out by one family. Every slide that you'll see here, the numbers are now outdated because we've waited a couple of weeks. So now there's almost 150,000 people living there, a bit over 51 square miles. Basically, they can start 15 new homes a day, and in 90 days, those homes are completed, sold, and occupied. And they're all site-built homes. There's 3 town squares. All the town squares have nightly music and dancing, 365 days a year. There's 3,600 social clubs, all built by the community. To give you an idea, one of the social clubs would be the softball club. The softball club has 550 teams and plays more games than Major League Baseball. And then you have the other 3,599 clubs. There's tennis, pickleball, golf. There's now 747 golf holes because they know that every time they're going to build 90 homes, they need another golf hole. Every 800 homes, another new 9-hole course. So last year, 4 million rounds of golf were played, and they have a whole infrastructure with road system, tunnels, and the like for golf cars, and there's now over 60,000 golf cars there. Part of the reason that they're really successful in the villages is because they survey the community, and they ask them, what do you need, what do you want? And their belief is that if the community asks for something and they can get it for them, they should. Not that they could, but they actually should. And about 12 years ago, when they surveyed the community said, what's really going wrong here is healthcare. We have the sense that our care is fragmented, people doing things to us that are not in our best interest. And with that, response was to build out, in essence, the Villages Health, which was a patient-centered, primary care-driven, community-based healthcare model. The only way to make something like that work was to provide a lot of time for doctors with patients. So, for example, we'll give our new patients who we don't know an hour. And people we know, we give them a half hour with a ton of support. So the behavioral health, audiology, lab draw stations, retinal eye scanning, all that's in the care centers, built out really to make sure the patients do incredibly well. So we're full risk for most of our revenue. By being full risk, it means as our patients go, we go. So if our patients do well, we do well. Our patients do poorly, we do poorly, which seems kind of fair. We have one EHR, which allows us to link all of the clinicians into one system. We have our own, in essence, analytics team. We do a lot of prep for visits to make sure that we do the things that need to get done for every patient, for every visit. Part of the challenge, though, when you do that, is the rules change. And as the rules change, we have to become a little bit more agile. We have to build in those changes into how we deliver our care. Part of it, on the risk-based side, is there'll be new things that get added in that say these were potential sources of revenue. You've already captured all the information in your medical record from previous visits, may have been years ago, but you don't know where it is and you don't know how to find it. Additionally, the measures for what quality is for HEDIS, those also change on a yearly basis. The ability to set all of that up allows us to make sure that we have ability for our clinicians to deliver the right care to the patients, so we enhance their quality. And if we do it in the right way, we then have revenue left over to put in new programs that, again, enhances the overall experience of the patients, how they do, and the performance for our healthcare teams. So that's what we were solving for. We really wanted to make sure we had increased revenue, improve the cost of care for our patients, maintain or increase the quality, and do it in a way that made our healthcare delivery team really happy with the work they do. So with that, I'm going to turn it over to Kevin.
Hi, everyone, and thank you, Jeff, for that wonderful introduction. I think as Dr. Lowenkron summed up, first of all, the village is an amazing place. I've had the pleasure of being there on and off for 10 years now. And innovation can come from many places. It can come from Silicon Valley. It can come from Cambridge, Massachusetts. It can come from Beijing. But innovation, particularly in care delivery, can come from Central Florida, especially when you have the commitment of a group like this with the opportunity and the ability and capital to build new things. What the villages set out to do was see how the entirety of the electronic medical record can inform their care delivery model, both in terms of a reimbursement, how can we capture all the appropriate reimbursement codes, and just as importantly, how can we make sure the care is delivered the right way. Health, we're a technology company. We serve academic medical centers, ambulatory groups like the villages, as well as MCOs to do just that. What we do is we mine the medical records, both the structured and the unstructured data, to find the insights that patients want to deliver. Growing out of Central Florida, we now have a national footprint, and Jeff's slides aren't the only ones that are out of date. With some of the new relationships we've secured, we can now fill in all 50 states, but just try to keep up with them a bit. Why we exist today is because the data that our clients need, whether or not it's for coding, for quality, for visit prep, for care standardization. Right now, it's not that it's not in the EMR. There's so much in the EMR, and then you add in HIE data flows, there's even more. The problem is it's really hard to find. And I think, obviously one of the major tech threads going around this conference is text analytics, as fueled by the hype around ChatGPT. And I'm so excited about that because realistically, the nuggets that our customers are looking for might be an old claim, it might be in a problem list, maybe a past now no longer active problem. Almost typically, it's buried in a very blurry PDF. And I love the villages. As I mentioned, I've been there for years. What I don't love is their document scanning. We've scanned hundreds of thousands of their documents, and every possible permutation you've seen, we've seen. Now, I tell our data science team the same thing I tell my 8-year-old son. You get what you get, and you don't get upset. It's not the customer's job to give us clean data. It's our job to find the insights regardless of how it exists. And and the same thing I also tell my 8-year-old, we do our best. To do this, to find the undiagnosed or uncaptured or undermanaged diseases at the villages and elsewhere, what we do is we provide two pieces of interrelated technology. The first we call whole chart analysis. This is where we aggregate structured data, claims, EMR, labs, etc., with the results of our NLP. That finds the work that needs to be done, and that helps prioritize the work. Unfortunately, while necessary, it's not sufficient. Analytics in itself doesn't move the needle. What we really try to do with a company and with a partner like the Villages Health and others is figure out ways to take that analytics and push it to the point of care, either ourselves, via partners, or via existing IT infrastructure that they have. How do we get them the nugget, whatever format exists, so something can get done? I don't care about data. I care about getting things done for the patient and the financial performance of the healthcare system. So why go through this effort? Tactically, what do we do? And why does the villages continue to hang around with a guy like me? The reason why we review millions and millions of medical notes every week and every month is to do four things. One, we got to pay the bills. No money, no mission. The euphemisms, we've all heard them all many, many times. But realistically, to fund the care that we all want to get, we need to help with billing and coding. We live in the real world. But just as important as that is we're able to find the quality in the gaps, whether or not it's formal measures like HEDIS, internal metrics, or general, specialty guidelines that might come out from an academic society, we're able to find them. What we've also found to be most efficacious is when we combine those first two bullet points. When you link the coding with the actual patient management is how we sell it to the docs and how Dr. Lowenkrown sells it to his docs. We don't code for the sake of coding. We code because that gives us the data to create the registries to make sure every patient gets treated. And I think this is really the beauty, particularly of risk-based coding, when you're starting to reward doctors for not ignoring disease, but embracing them and doing the best they can for the patient. The two other things that we do with this data is we summarize. Patient 360, patient views, patient summaries. I'm sure if you walk this floor, you'll find hundreds of examples. And many of them are great, and we learn every day from our competitors and our colleagues in the market. But what we're able to do is we're going to take the already structured data that exists and the newly structured information from our NLP and marry those together. And being able to look at those two data sets in total, in summary, while respecting data provenance, is what allows us to do the fourth thing, which is to create much more meaningful insights to the clinicians, even above coding support. How can we identify which patients qualify for high-intensity therapy, which ones need a referral for behavioral health, and everything in between. Data drives decision-making, it doesn't make decisions. Our job is to put that data, regardless of where it started from, in front of Jeff and his colleagues. So this talk and the results, the case study that I'd like to show the results of in a moment, addressing Jeff's problem will come up, but I just wanted to point out, if you're gonna go through the trouble of reading a chart and getting data and integrating, read it once, use it lots of times, and there's lots of reasons to do it. We work with ambulatory care groups like DEF. We work with academic medical centers. We do a lot of work in perioperative and oncologic care. and starting to really take on one of the other biggest problems of informatics and care overall was that transition from acute to SNFs and step downs. In each one of these cases, it's the same flow. We're not the panacea, but there is data that's buried in the chart somewhere that needs to be in front of them just to make the process work a little bit better, and typically, in some cases, a lot more profitably. So how do we do this tactically? Well, we try to do as much as we can for our customers because our customers have day jobs and have a lot of work to be done already. So rather than just give them an AI solution, a querying solution, a database solution, we try to take as much ownership of the problem as we can and accountability for the problem. We get the data, whether we build our EMR interfaces, we handle batch processes, we query the data, we give them out-of-box content for quality, for coding, but at the same point, I'm married to a doc. I've been fighting with docs for 20 years. I know when to give up, or at least I think I do. We let them define the system behaviors that they want to do, and our job is to implement it. And then lastly, we give them a menu. If you want to consume our insights via our API, via our UI, via our data export to Snowflake, that's their decision. Our job is to give them the data in the way they want to do it. So, good theory. Let's talk about what we did with the villages. I was going to say our tempest in a teapot. I'm trying to come up with a non-stormy analogy given the weather in South Florida these days. But what we did there was we started with a very simple problem to articulate. There were 4 diseases that they believed were systemically undercoded: macular degeneration, atherosclerosis, neurodegeneration, and pulmonary hypertension. And just this is the first project. This is now a couple years old. They were kind enough to give us an encrypted hard drive with a big pile of this and said, Kev, go figure out what's in there and see if you can get it done. In that hard drive, there's about 600,000 blurry PDFs and encounter data for 7 million encounters. We did some basic data cleaning on the structured data, deduplication, some throwing out clearly miscoded or lab tests that were done in 1901 or 2027, which were obviously data errors. We uploaded all this information and we went hunting. Just to give a sense of scale of this work, though, these circles are not in proportion. The structured information pointed out on the encounter side was dwarfed by the NLP results. To be clear, we started looking for a few conditions that the villagers want us to look for, but we were like, oh, that's kind of too easy. Let's see about what we can find in total. So rather than just looking for the 4 conditions we're looking for, we find everything in chart, every lab, every medication, every condition, every procedure, and whether or not it's for them, a family member, etc. And let's pull all that together. From halitosis to alopecia, to fear of the number 13, to atherosclerosis and the neurodegeneration that Jeff was looking for. We built a really big database, and for 10,000 patients, this was no big deal. But now that we're doing it for millions of notes, this idea of big data and NLP, if you could walk away with one message, be prepared to increase your storage costs if you're going to start reading charts. I have the bill to prove it if anybody wants to see them afterwards. So, we wouldn't be on stage if it didn't work. It worked quite well. We were optimistic going in, and we ultimately surpassed it. We found about 2.5 million in net new revenue from them from this pilot. That's 2.5 annually, most of which dropped right to the bottom line since they were already providing the care. We found to generate that, we found about 270 suspects. And more importantly than finding the suspects, what matters is what we didn't show, which was the demand for us is when we found a suspect, meaning a patient who had a disease, or an indication of the disease somewhere in the chart that wasn't captured, the demand was it had to be 90% accurate. So they gave us a little freedom. He said, I think Jeff would say, you ask a doc to open up a chart 3 times, and 3 times you get a miss, and there's not going to be a 4th. I'm sorry for stealing your line. But what we did was we surpassed that target. We found a lot new codes. We found it on 15% of the population. And I think most importantly, we gave them a lot more data than just these 4 codes, particularly on quality measurement and HEDIS gaps, which has served well beyond the pilot and gave us the confidence to build the interfaces and to turn this into a transactional system. Since this project, I think we're regularly looking at 18 to 20 commonly configured codes. I'm confident to say we've more than doubled the ROI there. And just as importantly, I think we're continuing to expand our clinical footprint within the organization. If it's going to be used, it's got to be useful. If I could have a nickel for every time heard Jeff and his colleagues and other customers say this, frankly, I could afford to exhibit here at HIMSS more often. But to make it useful, what we do is four things. The model's got to be right. It's AI. If the model's not right, nothing else is going to work. That's necessary but not sufficient. The way we were able to get these results at the villages was be able to look, don't do NLP in a vacuum, don't do structured analytics in vacuum, do them together. One thing, they're synergistic. If you have, for example, an EGFR value in a cancer patient, it likely means something than an EGFR value in a non-cancer patient. One's about cancer, one's about kidneys. Use that data sets together to inform one another. It's not just 1 + 1 = 2, but let the system read it the way a human would. Obviously, when I look at PAP in a man, I'm thinking pulmonary arterial pressure potentially. When I look at it in a female's chart, there's a good chance that PAP referring to PAP smear. So maybe a normal limit doesn't rule out pulmonary hypertension. That's the advantage of putting these two things together. The other thing is, as I mentioned, don't fight the fight. People want to find what people want to find. We're not clinicians. Our job is to serve it up. And then lastly, this is where we do a little proud of some of the art of this thing is when we mine charts, we find hundreds of thousands of insights of, as you'd expect, of varying quality. And I'm not talking about blurriness or unblurriness. But when you find, for example, a suspect, the patient might have a disease, what you find is, I'll take diabetes as an example. There are lots of times patient has diabetes. That's good. Patient does not have diabetes, right? We'll find that too and realize the same. Or to test to see if patient has diabetes. That's uncertainty. But even when you find things that on first order looks like the patient has diabetes, what we still see in the real world is very large practical variation in the quality of that score. So we developed an AI model that says, for all the stuff that you found that looks good, rather than kick it over the wall and let Jeff and his team deal with it, let's score it. Let's say how confident we are that this is really the nugget they're looking for. And we call that a strength of evidence score. We're starting the patent process on this now. And we're very excited about this because it's solving a practical problem, both for ourselves internally when we audit our work, and more importantly, it makes the lives of Jeff's coding teams and his clinicians easier. There's a lot more to practical and tactical deployment of AI than just a great model. To be fair, we do love our model. We actually validated the raw model performance at University of California, San Diego. We published this in Anesthesia and Analgesia last year. Our model beat docs. And it's not that our model's smarter than docs, and I'm not just saying that because I'm married to a doc. Our model, though, is very, very good at a very specific task, and it doesn't tire. So when we were able to benchmark the performance of our model against clinicians, what we found is about 85% concordance. The model agreed. The stuff where there was dissonance, what really happened was the doc's tired, they cut a few corners, and again, they're people, they're busy people, and the model doesn't tire. There's a couple of cases where the model, as you would expect, missed some things, and this is always a journey, not a destination, and we're constantly trying to get better at that. When it's all said and done, though, I love talking about analytics and practical and tactical deployment and how we partner with customers. It actually has nothing to do with it. It's not about the data. It's not about the dollars. For us and for Jeff and for all the villages, it's about dancing. And it's just been an absolute pleasure helping Jeff and his team get the outcomes that every villager demands and deserves, and figuring out a way to scale this nationally. So on behalf of my partner at the Villages Health and Cade, thank you all for listening, and thank you for embarking on this journey of text analytics with us or against us. And in the back, there's a full write-up of the case study, access to the published paper that we put out from my colleague Jody, who's sitting there waving furiously at me. So thank you all for attending.